Yes, I am Elizabeth McQueary. I'm an occupational therapist. I am also the patient navigator at the Banner Sports Medicine and Concussion Center. Thank you, Beth, for having me. I'm going to walk us through a little bit of concussion rehabilitation with the focus on visual function through the eyes of occupational therapy. So following today's session, I really want to make sure that we kind of attain some basic learning objectives, one of which is going over obviously a quick concussion review, definition of concussion, understanding the pathophysiology, and recognizing common signs and symptoms, which I think is kind of a belabored point sometimes, but it provides a good basis for conversation as a result to what I do here at the multidisciplinary center focused on concussion management. We're going to recognize persistent visual deficits post-concussion and identify some functional implications of those visual deficits. And we're going to talk about the consideration of visual rehabilitation approaches, both traditional as well as modern, where I'm going to tie in the SMARTfit in my conversation. I'll introduce some goals that I kind of write in my therapeutic process, and we'll go over a case study as well to kind of wrap it all together. And finally, I do want to make sure that I address some resources for additional resources should you want to continue to learn more about your interests and feeling an interest in functional visual rehabilitation moving forward. It's a topic that I'm very passionate about, and I hope that I leave you with lots of information. Okay, so what is a concussion? It's a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. So obviously, it's a significant public health concern worldwide. We do know that it does not necessarily have to be a direct blow to the head. It could be a blow to the body that causes the brain to kind of shake violently within the skull. A loss of consciousness is not necessarily required for the diagnosis of concussion, though we do know that it typically results in common symptoms that follow a sequential pattern of recovery, typically rapid onset of short-lived neurological deficits that spontaneously resolve, but also can remain persistent symptoms following the injury. We also know that structural imaging is unremarkable, and so positive MRIs and CTs are not something that we would likely find in the case of concussion. However, the persistent functional disturbances that persist are the things that we work with here at our facility. I can take this moment to talk about the fact that our facility, we typically see patients within about even as little as a couple of days to a couple of months after injury. The average is about 1 to 2 months post-injury. We do have a couple more prolonged concussion onset patients, but typically with less than 3 months. And we see them initially beginning with a physician and working with other subspecialties here at our clinic. So in addressing some of those functional deficits, multiple disciplines can assist in the management. We're very fortunate to have all of these specialists here in our clinic, with the exception of speech pathology. We don't have that currently, but we start with our physician. The patient would come in and see our physician for care, and he or she would identify some areas of deficit and then order relevant specialties to follow. So we do have neuropsychology, neurooptometry, a neurologist, athletic trainer, physical therapist, and of course myself as an occupational therapist. We also utilize some other providers in our community that are connected with our Banner Health system. So sometimes we utilize audiology services, counseling services, sometimes even chiropractic care. Many disciplines in general can assist with the management of concussion symptoms. But again, today we're going to focus mostly on my role as an occupational therapist and my relationship with my neuro-optometrist, who evaluates for visual deficit. So I won't go into detail here, but that's a picture of myself and my colleague who I work with on a daily basis treating our patients here at the Concussion Center. She's a neuro-optometrist, which is an optometrist, but just he did a couple more periods of study focusing in visual deficits with neurological conditions. And then on the right is myself. I'm an OT, and we work well together to kind of address a lot of the symptoms and rehabilitative efforts towards helping our concussion patients here. I typically see patients after they've been seen by the neuro-optometrist, though I can sometimes evaluate them before, should the schedule allow. So multiple people can assist in management, but also multiple tools can assist in management. I wish there was a magic thing that helps everything and all things, but I think it helps to kind of come from a global perspective. So here in my slide, I have a lot of the activities and tools that we have here at the clinic, some of which we don't have, but things that I've familiarized myself with just throughout the years. Most specifically, we have this computerized posturographer machine looking at balance and kind of in a visually immersive environment. I utilize some visual therapy tools as directed by my neuro-optometrist, things like prism lenses, free space fusion cards, anti-suppression, stereopsis cards. These are things that are very vision therapy specific, but I am able to utilize them under the direction of a neuro-optometrist. But some of the things that I use that are more functional, like this Marsden ball, the Brock string, these blocks here, which we'll talk about momentarily. And also, of course, obviously, why we're here to talk about today is the SMARTfit. And so this is a tool that we're so lucky to have attained here at our facility. And I use in therapy for occupational therapy, and my coworker is a physical therapist, also utilizes this tool as well. So we'll talk about that as we move throughout today's presentation. So identifying persistent symptoms after concussion, looking at the visual considerations, is kind of going to be the bulk of our conversation today. So did you know that there are over 30 areas of the cerebral cortex and over 10 areas of the brain stem directly involved in vision? So I really think this is a great slide. I love this little caricature here. It really plays well into kind of understanding the amount of connection between vision and brain. Just recently, my patient this week, she said it perfectly. We were doing therapy together, and as she was working, she said, I think that this therapy is more for my brain than my eyes. And I said, yeah, that's what we're doing. we are working on your brain. And so I think it really clicked for her after kind of talking with me and going over some of the things that we're working on. And so sometimes I think it's funny that people don't recognize vision as such a integral part of the brain function, but it's just so important to consider vision in the context of brain injury. Studies are showing that 90% of traumatic brain injury patients suffer from some level of visual dysfunction, and they may include, but are not limited to, blurred vision, sensitivity to light, reduction or loss of visual field, headache, visual tasks, reading difficulty, difficulty with eye movements, and the list can go on and on. This is a picture image that I stole from Rehab.org. I have put it there at the bottom. We'll talk more about this resource, but they have a lot of information and research available that talks about vision and visual rehabilitation in the context of TBI. So I just wanted to kind of make sure I start there, and we'll circle back to that later in the conversation. So vision is just so much more than 20/20. Many of my patients come into my clinic and say, hey, my vision is just fine. I can see 20/20, even 20/15 sometimes. I don't need glasses. I'm great. But I really spend a lot of time educating them that vision is more than just how well you can see. Obviously, being able to see well is important, but under what lens condition do you need plus or minus lenses? What is your eye health? Are there any eyelid problems, dry eye syndromes, traumatic injury to the eye, pupil abnormalities if they exist? Those are all really important and relevant in vision. but so is too the efficiency in the way we use our eyes and processing skills. So how well do we gather the information from the world around us, and once we have that information gathered, how can we interpret that information? Are we accurate with making decisions about how far or close something is to us? What is the texture of that item? Is it moving toward me or away from me? What's the trajectory of that item? Should I move to the right or left? These are all really important pieces and facets of vision that go far beyond just what you can see using a standard Snellen and eye chart. So we're going to kind of harp on those processing skills a lot today, and how considering those skills and deficits can be used to kind of plan your care moving forward. So I would be remiss if I didn't talk at least a little bit about some research studies that support what I'm saying. So this study here, completed in 2007, is a retrospective study. It looked at a group of 220 ambulatory outpatients with acquired brain injury, and 160 of them were a mild TBI group, and 60 of them were more in a stroke injuries. So the study found that most of the visual diagnoses in the mild TBI group were centered around ocular motor and focusing problems. So looking at accommodative issues, urgent issues are most common in TBI, and more of the obvious, like to the naked eye difficulties, like an eye churn, strabismus, or nerve palsy was most commonly found in the CBA group. So this study is just a good example to alert the clinicians who I work with every day, some of which are kind of new coming on or residents, just kind of alert the clinician to consider the high frequency of the occurrence of ocular motor dysfunctions in this population and that impact of their quality of life. So things like tracking and focusing for someone who has a full-time job as a driver of a bus, or who may be someone who has to climb, electrical poles. Think about how much these types of deficits can affect their daily living skills and their overall quality of life implications. This next study was completed in 2016. Mitch Scheinman and his group looked at adolescent athletes with an average age of 14 and a half, all of which are post-concussion, and to be fair, were all part of the concussion program. But the study found that 90% of the patients did have an identifiable visual dysfunction, as well as 69% of them had one or more of the following. So accommodative, so focusing problems, convergence insufficiency, and saccadic eye movement disorder. And these are all really important implications to think about how important that would be for a 14-and-a-half-year-old whose main occupation is school. So it kind of indicates that comprehensive visual exam will be really helpful in the evaluation and treatment of concussive injury, even if it's just to support some academic accommodations that would be relevant for this group, so as they're returning back to the classroom or back to their sport. And lastly, this quick study in 2012 assessed the occurrence of visual dysfunction and associated symptoms in active duty warfighters during subacute state of blast injury. So this is kind of an interesting one for me. It's not necessarily a direct blow to the head or body, but a secondary blow from a blast. And it was interesting to me to notice the clinically significant occurrence of these ocular motor and divergence problems with these warfighters compared to the non-injured control group. So all of which were statistically significant and relevant for us to think about when looking at these groups, even if it's just not an outright blow to the head, which some clinicians kind of think about only. So this is just kind of a helpful study in that. So just as a quick recap, it's important to consider common visual problems after concussion. My understanding is that on this call, obviously there's some occupational therapists and physical therapists like myself, but also maybe some clinicians, maybe some coaches for teams, or people who work kind of in the more tertiary setting that might be identifying these problems with their folks that have experienced concussion. So I think it's just important to consider that questions are important. Asking these people these questions about, are they having sensitivity to motion, sensitivity to light, balance problems, difficulty with eye movements, depth perception changes, headaches, eye pain. These are all things to consider and look for and likely expect if there is a suspected brain injury. One of the most powerful tools I think that I can share with you is to consider using some type of survey to elicit some of these answers to the questions that may not be easily observed in the clinic. So the Brain Injury Vision Symptom Survey, so the VIESS, is a validated 28-item questionnaire, very easy to use. It's a tool you can find online on the NOR website, but it's a tool to assist in making those referral decisions. So I believe on the PDF of the file here, it even tells you if higher than this number of symptoms, consider referral. So you can use this tool as a way to kind of bridge that, do I think there's a visual problem here more than just my suspicion? Utilizing this survey is a great tool for that. And here at the bottom, I have a little link. If you type this into your Google search, you should be able to pull up the PDF of that survey. So when they are seen by a neuro-optometrist or another qualified subspecialty, many of the visual problems will fall into one of these three categories. So we have ocular motor dysfunction, so a dysfunction of the tracking system. So doing things like smooth pursuits and saccadic eye movement fixations are difficult. Here in this example, kind of following these little small animals to the adult version, following that line from the puppy up to the dog is easy for me, but definitely more difficult for someone who's having some ocular motor dysfunction. Binocular vision dysfunction, so the pointing system, so how the eyes are teaming to kind of converge or diverge together. People with these types of dysfunctions may complain of double vision, blurry vision, or just overall visual confusion. Working on the computer can cause headaches, dizziness, eye pain, etc. Accommodative dysfunction, not last but not least, is kind of the dysfunction of the focusing system. So how clear we can focus, changing focus from near to far and changing back and forth. So this is kind of an example of what kind of a difficulty with accommodation might look like when looking at something at a reading distance. So we've talked a little bit about what to look for in terms of the visual deficits. We'll talk more about that as we go into kind of a treatment plan. But we're going to talk about treatment considerations. I'm going to consider some traditional concepts as well as modern frontiers, where I'll tie in the SMARTfit here shortly. So in general, in terms of occupational therapy and addressing someone's needs and increasing their independence and function, I think about starting from where they're the most comfortable and kind of gradually increasing the task demand. So grading the activity from something as simple as staying in supine position, tracking, moving to sitting, standing, adding a balance challenge, distractions, dual task environments, or cognitive loads. And so for the purpose of today's conversation, I'm going to be thinking about using some of my activities in the clinic, but also tying in SMARTfit with some of these different positions and standing and adding in balance challenges, dual tasking, cognitive loads. So we'll keep that in mind throughout the next few slides. But before I get too far on that, I do want to touch base quickly on kind of consideration for treatment planning in terms of vision retraining. I don't know what level of confidence many of you have with looking at vision rehab, but I can speak for myself that when I started this journey 8 years ago, I thought, wow, I am overwhelmed with what there is to know about vision rehab. I just don't know where to start. And I connected with now a friend of mine, but a colleague and mentor, Dr. Deanne Fitzgerald, who is a neuro-optometrist here in the States. She's just a wealth of knowledge, and I just love picking her brain. But she really helped me to put my mind at ease and focus my mind on what therapists do well, which is a focus on function and looking at the environment. And that way, rather than kind of focusing on some of the things that are a little bit beyond my scope in terms of vision therapy, she really wanted to kind of highlight the importance of starting peripherally. So many of us may have heard of things like, okay, if there's a convergence problem, we're going to push right into some penciled push-ups or maybe the frog string or something. And Dr. Fitzgerald shared that it might be more important for you to start where they're, again, more functional, more comfortable in the peripheral space, and then kind of gradually, as they're able, kind of shift our focus more toward the central vision. So as not to kind of overly centrally bind the patient. So they're already uncomfortable here. They're already closing their visual space here, usually when they come into clinic and they're having headaches and eye strain. So we don't want to start here where it's already uncomfortable. Start out here to kind of work on that central and peripheral integration. And when I thought of it that way, it really helped me kind of go back to my tool bag of being a therapist and thinking more functionally and how that person might engage with their environment. And I really, in using that principle, I really like to utilize large-scale activities for gross motor movement and then move into fine motor. But I really feel that the SMARTfit can really kind of tie in here with that same model and increasing peripheral performance. We'll talk about that here as well. So I think the most important part of thinking about treatment is thinking about the symptoms and their effect on function. So ocular motor, we talked about this. This is just difficulty with eye tracking. This patient will likely have difficulty with reading, skipping lines, having poor attention, difficulty with copying things in class, drawing, coloring, difficulty with frequent change and fixation and accuracy of eye movement. All of these things can certainly worsen with fatigue and stress. So that's really important to point out, and I'll keep pointing that out as we go along, that a lot of times the person doesn't think about it right away until they're actually doing something. And that's when the symptoms arise, and that's when they start to notice, wow, I do have a little bit of a vision problem here, and I don't know what it is. So I'm kind of a visual person. I like to have a picture in my mind to kind of stay, to remember some concepts. So I wrote down some common reports from my patients that I'm currently seeing now. So my eye feels tired when I read or work on the computer. This is a common complaint after concussion. And many people who I see are working adults in college or working in the community, and they work on the computer all the time. So clearly this is an area of focus for these folks and how that's really impairing their function. So this is an example of a normal tracking. So we perform these small incremental eye movements to kind of follow along the sentence, come back to the first part of the sentence, and continue throughout and back to the line. This is an example here of poor tracking. So this person might be kind of jumping all over the place and certainly skipping lines and having difficulty paying attention to what they're reading, and thus poor reading comprehension and poor recognition of what was actually read. So intervention. So what would I do? So first of all, I wanted to kind of put a sample goal there for you to kind of consider. This one, I speak about performance using the DEM test, which is an evaluative tool that I use called the developmental eye test. This is a very easy, simple, objective measure that I use on most of my evaluations. It's basically a task in which the person is reading numbers as quickly as they can, and it's timed, and I have some normative data about how quickly they should read the panels that are provided. So based on the performance of that, I can kind of gather some information about their tracking and their ability to track and perform pursuits. I might utilize things like here in the foreground, I have these Marsden ball. The Marsden ball is you can buy this online, but I also make one with a softball or a tennis ball tied to a string hung on the top of the ceiling, and I can use it in a swinging pattern, side to side, side of the periphery as well. having them track the moving object. Again, looking at that large amplitude eye tracking movement, starting in the periphery, and then kind of working more inward. Inward, I might work on some tabletop activities like word searches, computer programs, worksheets that I make. These are all types of activities that I might use in the treatment of looking at pursuits to improve function in that area. In terms of saccades, I have a simple goal here. This goal is talking about performing visual saccades activity times a couple of minutes with a minimal increase in symptoms. And here I'm referring to the PCSS scale, which is a scale we use here at the clinic. It's just looking at just overall post-concussion symptoms. And it's on a scale of 0 to 6. So many of my goals will have that out of 6 reference to it. But here I can utilize multiple different activities looking at eye tracking and saccades for quick, accurate eye movements. In the foreground of this slide, I have what are called multi-matrix cubes. I really like this activity. I have the website here also for you at the bottom of the screen. This activity is an inexpensive activity you can purchase online. It's a great tool for looking at attention, memory, reading, visual scanning, bi-hemispheric integration using both hands to manipulate the cubes. There's tons of ways you can load with brain loads and cognitive demands. I really like this tool. I use it also, it can be a tabletop activity that I can make kind of small and compact, or I can make it a lot larger, or it can be kind of a bigger space which they're kind of performing those saccades. And I think it's a great kind of segue into utilizing more sophisticated equipment. So on the next slide here, I am talking about some visual tracking charts. On the left, you'll see I have these charts here. I use this picture from the website icanlearn.com. This is a great resource for you as well. They have tons of some printable charts you can use for your clinic to kind of look at working on some eye tracking activities. These examples here, this one is a 10 by 10 chart. I'm looking to have the person read from the outside columns down and work their way in. You can imagine toward the middle, those middle 3 or 4 columns can be very difficult and challenging for someone who is having those tracking difficulty and difficulty with endurance for that task. Down here at the bottom, I have the example of what I call the 4 corners. So in this case, I have these 5 by 5 charts that I cut up here. I cut each one out, and then I would put them on a door frame or a wall about 3 feet apart from each other. And I look at performing visual saccades using from one letter, so V, F, O, N, S, N, E, C, and so forth. And you can imagine how that would be difficult for someone who has a tracking difficulty or poor endurance for such a task. And of course, difficulty when you get here in the middle, kind of losing your place, you travel from one chart to the next. So in my therapy, I see the person once a week for about 45 minutes to an hour, and then I give them some home exercises to do. This is where I think these are really great. They're home activities, they can do them at home, working on their skill and their endurance for the task. And then in therapy, I can utilize some of the things they obviously can't take home, like here with my SMARTfit mini system here, I have my clinic. This is my coworker who I have doing some acrobatics for me. She's standing on the Bosu ball, holding a medicine ball, and performing a tracking activity here. You'll see I have some colors here. This is a still photo, but I do have videos later. So obviously there's some auditory feedback when she strikes the target. She's having to balance as well. And so there are ways that I could obviously grade this activity as well from a seated position and then kind of graduating up to this dynamic balance challenge. So here in these next 3 videos, I have a gentleman who is actually a current UFC fighter. He was injured, actually not in a fight, but just outside of the ring. But he did have some concussive injuries. And so we've been working with him here both in the vestibular therapy and visual rehab. And I use the SMARTfit with him very often. In this video here, he is performing a simple performance of just tracking the item. I'm having him keep his head still and just using his eyes to track the target and jab as quickly as possible. You might have heard some positive sounds and negative sounds there. The negative sounds indicate that he didn't hit the target quick enough. So again, I had that on a chase program so that I timed it to where he had to go faster and make sure he hit it at the time appropriate for what the demand was for that task. This next video down here at the bottom, I have him moving his head a little bit more of a sport-specific performance and the bobbing he might do. I also have him calling aloud where or what he's hitting. So he was counting aloud with the numbers, 1, 2, 3, up to 10 in this example. I do have the SMARTfit lifted to the top to kind of facilitate some overhead reaching as we're working on increasing his ability to have that overhead reach for a speed bag that he's trying to work up to. His injury was kind of more neck related, so that was something that we were kind of working in therapy to get his balance or get his tolerance for that type of activity. In this last video, he is standing on the BOSU ball. Physical therapist is there behind him, holding him just to make sure to fall over. But he is identifying targets here on this board and trying to do it quickly in that kind of sustained squat position that he was in. So kind of here's an example of kind of seeking a specific target with inclusion of dynamic balance, that dual tasking. I had him looking for the target and I had him identifying which position on the board he was finding the targets in. So there's 9 spots here. I had him saying, 1, 6, 8, 9 on where he was looking on the screen. So he loves this activity and I use it with him quite often. So going back to looking at some of the visual symptoms and the effect on function, how we would tie that into some more therapy. In the binocular visual dysfunction area, so these folks will be complaining of maybe some intermittent double vision, discomfort and eye strain for all or most tasks, easily fatigued, poor concentration, difficulty in change and eye-hand coordination. This is particularly important for our athletes that are working on, striking the ball at the right time as the ball is coming toward them. Can they meet the demand for that hand-eye coordination to strike the ball at the right moment? Obviously, they would have difficulty with activities that require accurate stereopsis or accurate perception of three-dimensional space. Again, for things like sports, driving, awareness of the peripheral environment. Again, all these symptoms can certainly worsen with fatigue and stress, and that's important to think about when asking or looking for some of these deficits. The accommodative dysfunction, so symptoms and the effect on function. Eye discomfort for most visual tasks, blurry vision near and far, easily fatigued, poor concentration, poor attention, loss of place with reading, and difficulty with all things that require sustained close work. So again, these types of deficits can certainly worsen with fatigue and stress. So types of reports I get from patients just throughout therapy is, I notice that when I'm doing something, I close an eye when I'm trying to focus, or I sometimes see double. I think this is a really good one because sometimes if you ask someone, are you having double vision? The answer is no, but yet when we're talking with them in casual conversation, I see them closing an eye while we're talking. And I'm wondering if they are seeing double, but they're kind of compensating for that by closing an eye or turning their head in a way to kind of use a more dominant eye. Becoming easily overwhelmed in busy environments or with busy visual tasks. So these are two really common environments that are challenging for someone who is having binocular visual deficits or cognitive dysfunction. So here with driving, we've got the coffee cup in the foreground, our dashboard in the middle. In the distance, we've got the signs on the wall or on the buildings ahead, the traffic signs, people coming and going, crossing our paths. Imagine if this was at night, or we had a lot of glare from the lights in front and behind us. This is a very busy environment and can be very problematic for people with these visual deficits. This picture on the right here, I like to refer to as grocery store syndrome. So, so many folks can talk about, their hesitancy with going into the grocery store after concussion because of some visual or vestibular deficit. It's too much, too loud visually. There's a lot of things happening. People are coming and going, looking for one item amongst a lot of other items are very difficult for this person to process. And sometimes they go in the store and they just head right back out. So goals to be able to tolerate such an environment would also be a good place to start when thinking about rehabilitating some of these deficits as well. So I'm noticing that I'm holding material closer or farther than usual. This example here is perfect. This gentleman here is obviously holding his paper at an exaggerated distance to read the small text. Obviously, he's an older in age gentleman, but I even have some young kiddos who do something similar to this, who maybe don't endorse visual problems. But when I see this happening, we know that something is going on visually. I can even go get them in the lobby, and sometimes I see them holding a cell phone this far out, not being able to see the text or turning their head and see it. And so that can suggest an accommodative issue. And this report of difficulty switching vision from near to far. So maybe in the instance of someone who is attending university and they're in a large classroom setting, they're maybe in the back of the classroom and have to shift their vision frequently from their laptop in front down to the speaker in the distance and returning back and forth. So that accommodative refocusing over and over and over can be quite challenging. So here's a sample goal for you, looking at some Virgins training and just performance and that type of skill, binocular visual skill performance. In my example here in the back, I do have a Brock string. Brock string is something that is widely available online. You may have heard of that before in school or just in your work environment. I do think it's a great tool. I just don't use it right away. I typically would involve the Brock string a little bit later in my plan of care, just so that I'm not kind of focusing in the area where they're having the most trouble, which is usually central, and I focus more peripherally, at least in the beginning, until I know a little bit more about the visual diagnosis. I usually introduce the Brock string later on in therapy, typically maybe 3 to 4 or 5 weeks in, to avoid that central binding. I think throwing catch activities, like throwing the ball to the person, having them catch it with one hand or pass the other one, or catch with both hands, or even doing that monocularly and binocularly, is another great way of being able to integrate that central peripheral integration before kind of pushing into more of these centrally focused tasks. There are ways you can do this also with the SMARTfit, and we'll talk about that in just a moment. So accommodation. So this photo is not a photo that I took. This is actually from a website called Bernell.com. Bernell is BERNELL.com. I don't have that written here, I apologize. But it is a website where they have a lot of vision rehabilitation activities, some of which are able to be purchased from the public. But in this example, she is looking at a small chart in her hand, and she's shifting her vision from the small chart text up to the identical large chart on the wall here in the distance. It's cut off here in the photo, but she's going back and forth in these near to far charts, clearing the text as she goes on. So here we're trying to work on increased tolerance and efficiency with clearing different distances in space. And there's just a lot of ways you can utilize this type of near-far activity. Also important here is just educating on compensatory strategies. So if the person has been seen by an eye specialist and has been recommended to wear glasses, whether for reading or both, if they're bifocal or progressive, kind of ensuring compliance with spectacles is top of the line as far as addressing accommodated deficits initially, and then kind of encouraging energy conservation, thinking about ways you can modify the environment, enlarging the print, and so forth. So lastly, with kind of thinking about binocular skills, accommodative skills, I want to go ahead and think about visual processing and cognitive skills as well. So how are we kind of utilizing the information that we've gathered and using that into our processing performance? So in this example, I love using the SMARTfit, kind of ties it all together. There are ways that I can incorporate some cognitive activity, some binocular activity, near and far activity with the SMARTfit. But if I don't have the SMARTfit available, I can also utilize things like park retrieve blocks, visual memory games, visual discrimination activities. Again, I kind of referenced the website icanlearn.com that has a lot of activities there that are kind of that do address some of the aforementioned deficits that we talked about. In this next slide, I have examples again with my fellow who is my fighter. In this activity, I have him recognizing a pattern on the display board. While he's doing that, he's kind of involving some peripheral integration by kind of walking in a figure 8 pattern, or running, I should say, around these cones. And again, I am asking him to call aloud what position the number that he's finding is in. So he has to kind of override the signal to say what he sees, but say where it is instead. So I'll show you that. I know that the volume isn't really there, but here he is going around the cones again. Right. There we go, and continue. So I only have these 10-second snippets because this PowerPoint would be super long if I didn't. But this is a great one to utilize to address all of those deficits that I just mentioned. In this bottom video, I have a gal. She's a basketball player. I have her kind of bounce the basketball. I'm going to find two things that match. And I have her saying aloud a word that begins with the letter that she just found. So she's in high school. She's a high school basketball player. I'm trying to have her do kind of dual tasking with a cognitive load, but I'm also kind of integrating her sport-specific activity and that central peripheral activity that I was talking about. So we're working in her periphery, but we're also using kind of her central focus to kind of find the target on the target board in the SMARTfit. And in this last video, my gal is kind of spinning around looking at the pod. So I have the pod set up here. She's going to be looking for a target, and in doing so, she's kind of turning and using quick head turn movements to find what she's looking for. And in this example, she kind of didn't see that bee that was right in front of her the whole time. But this is just an example of the way you can use the pods. I also like using the pods on the ground, so I take them off of those. See this little stand here? I take them off and I put them on the ground, so they have to kind of look up and down or travel around the room, looking and searching for the target that they're supposed to strike. So I want to kind of take a minute and talk about a quick case study example. She actually is a current patient of mine, so I'm talking in past tense, but also current tense as well. She's a 19-year-old community college softball player. She was injured March of this year. The mechanism of her injury was that she was practicing catching ground balls when one of those balls kind of came up awkwardly and ricocheted off the ground and struck her right on top of her nose. At the time of her injury, She denied loss of consciousness. She did not have post-traumatic amnesia. However, she did endure significant dizziness, difficulty concentrating, mental fog, and she experienced substantial academic struggles after that injury. So much so that she sought care, and she kind of found us about 2 weeks after her injury. One of her biggest complaints was eye strain with prolonged computer work. This was a third concussion for her. She had 2 prior concussions in softball, but this one blow to the head really had been kind of prolonging her symptoms more than they ever had before. And within a few weeks of being with our provider, she did see a neuro-optometrist, and she was diagnosed with convergence insufficiency and divergence insufficiency, so some binocular visual problems, as well as mechanic eye movement disorder, so the ocular mobility problem. She was recommended to obtain specialized prism lenses to begin therapy here at the center with me in occupational therapy. And she had previously been engaged in vestibular therapy with physical therapy prior to seeing me. So just really quickly, my OT evaluation, I write a pretty darn good soap note each time I see my patients, but I'm looking at, I do an extensive patient interview, we review her symptoms, we go over her current performance and in what she does and what she needs to be able to do. Obviously, I take into consideration her personal goals and limitations. My basic screen usually includes near point of convergence, static eye movement assessment, pursuit assessment, the DEM, which is that developmental eye movement test that I spoke about earlier, or also the King-Devick test, which is also a similar tool. Neuro-rehabilitation, which is a card that I use to kind of determine if she's more exophoria or esophoria on the card that I have. Also available online. You can purchase something like that. I can talk about that a little bit further if you'd like. I look at her amplitude of accommodation and stereopsis using some other tools that we have here in the clinic. I did not utilize the following screens, but they are possible. I'm sure that Brian spoke a little bit about the BOMs. The MOCA I utilize for cognitive, when I suspect that there's a significant cognitive impairment included, and there are a myriad of different types of visual processing assessments that one can do, paper, pencil, and computer-based. I identify deficits, create a problem list, develop goals, and my plan of care is defined. Usually I see people, my plan of care generally is about 5 to 10 sessions, and around that 5th session, I would have them reassess by neurooptometry to kind of make sure we're on the right path and see if there's any changes to the plan of care that needs to be made. Sometimes I do need all 10 sessions or more, but typically my average is about 8 to 9. All right, so in this particular case study, she had a pretty significant near point of convergence. She broke around 8 inches. So as I brought the tool to her nose, she was unable to maintain fusion past about 8 inches, and I had to pull back to about 11 inches in order for her to recover that fusion. Looking at her smooth and saccadic eye movements, I graded her 2 out of 4, which is kind of poor performance there. There was notable head movement, grimacing, and dizziness reported. She oftentimes kind of averted the task as we were doing it and needed a lot of opportunities for refixation during assessment. When we did the DEM, which I have here in the top right of my screen, her norms or her time values were well below the norm. These are test A and test B. You can see these kind of straight down the line. Here are 2 columns here of numbers that she's reading quickly. And then test C, or the panel C, is the numbers that are presented horizontally, but in kind of this scattered random pattern. She has to kind of keep her line despite that. So her performance on that was also not good. Her neuro ranges were high. She was a 10 exo. The norm is typically between 2 esophoria and 8 diopters of exophoria, and she exceeded that a little bit even with her glasses in place. She was very symptomatic with all assessments and therapeutic activity. So treatment Involved, obviously, a substantial patient and family education. We did work on some tracking worksheets. We talked about earlier today the Mars involved, some of those tabletop activities with the blocks and the cubes, charts on the wall for oculomotor activity near and far. We did utilize rock string, prism flippers, and free space fusion activities that were recommended by my neuro-optometrist. And of course, some endurance training with some home programs to go ahead and build her endurance when she wasn't here in the clinic with me. And of course, concurrently, she was undergoing vestibular therapy as well. This is actually the patient. We're working on the SMARTfit here. This first slide is just a basic, simple tracking with a cognitive load. I'm having her verbally identify where the target appears on the screen, and she's doing it with the metronome. Good. Again, not moving her head, just kind of using her eyes to track those targets. On this next side, she's doing something similar with simple tracking. Simple being there's just one target that's being presented at a time, as opposed to seeking demand. But here she's having cognitive load in the decision making, in which she had, if it's a green circle, she hits the target. If it's a red X, she does not hit the target. So we're kind of looking at that inhibition. And again, she's calling aloud where that is on the board. I do that a lot with my patients, and I don't know, it's my thing, and I go with it, and I enjoy making that a challenge for my patients. This next one here, we're looking at her dynamic balance and gaze stabilization. So keeping in mind that athletes are never always still, they're always kind of in motion. We're trying to make sure that their visual efficiency skill and processing skills are accurate even when they are in motion. So here I'm working with my vestibular therapist, and we're challenging her with gaze stabilization and performance using the SMARTfit as she's bouncing on the BOSU ball. So here she's looking for the target that matches the target she found. She's using her back chair a couple of times, but she is trying to find them as she's bouncing up and down. So trying to keep her visual gaze stabilization stable as she's performing that motion. And this last video is kind of cut off, and I wish it wasn't, but basically what she's doing is running back and forth from the board and backward with that forward and backward ambulation, kind of having that near-far visual task. And I'll just play that up here. So she did that quite a few times there. All right, so we are still working together. We're in our, gosh, I want to say 9th week together. Since we started, she has begun to work 2 jobs. She is having good tolerance with working those 2 jobs, which she initially could never have thought of doing when I first saw her. She did obviously attain her glasses, which she's wearing full time, but she actually has kind of gradually decreased her reliance on them. So she wears them all the time, but initially when she woke up and even just walked around to her bathroom without them, she felt unwell. But with them, but now after several weeks, she can kind of, get by without having them on her face at all times and not feeling that increased reports of headache or eye strain. She normalized all of her previous assessments with glasses on or off, which is very encouraging. And her near-phoria, though still high at 7XO, is improving. She reports decreased all of her symptoms, and so much so that she felt comfortable actually transitioning from community college to the university setting. She did decide to end her softball career, which was kind of something that she came up with on her own with her and her family, given this is her 3rd injury. But she's very hopeful and looking forward to pursuing her academic career at the university here in a few weeks. So I find that really encouraging to know that, she has returned to her prior level of function, even better than that. So SMARTfit is a smart choice. I really enjoy this tool. I use it every day with almost all of my patients. And my anecdote with my patient I just spoke about, she loves it. She refuses to leave without doing something on the SMARTfit. So she wanted me to make sure that I threw that in this presentation as well. So I think it's important to just talk about just my opinion on the value of investment of the SMARTfit. This is just a great tool. I mean, I think it really just advances an otherwise basic care plan. It makes it more engaging and motivating for the patients to use it. I use it for patients of all age groups. My youngest right now, my kiddo is 7. My oldest is 70, and I've used it for anywhere in between as well. So I think it's just so versatile in that way. It maximizes my ability to treat in that time. So I know as therapists, we're kind of looking at minutes and trying to maximize the time that we have with the patient. And using the SMARTfit, it's as simple as just utilizing my iPad with the screen and trying to change things up right there as I go. I keep it fun, I keep it light, it's exciting, and it kind of gives the patient a little bit of insight into how they're doing, because you can show how they performed one day to the next. One of the newer things that I find really helpful are the dual cognitive tests, excuse me, and the retest potential that exists with that. On the bottom of the advertisement for this seminar, there was a link to one of the videos that TJ and his team did that I thought was just excellent. I couldn't do it justice, so I encourage you to go check that out, and talks about the benefits of that tool and how it can kind of encourage other recommended training programs based on how they performed. And then you can retest that person and show objectively how they improved over time. So that's just a great time saver to print out data that can support the benefit of the therapy that's being provided and assist in effective and clear documentation. So I just can't say enough about it. I think it's wonderful, and I think particularly in what I do with vision rehab, I can use it in so many different ways, and I just really appreciate this tool in my clinic. As promised, I do want to just quickly go over some online resources. Obviously, smartfitios.com is a great resource. They have amazing free video webinars on there, which really go into far more detail than I could even go into about how it was created and what are some ways you can use the tool. Also, YouTube is a great location to find some ways to use the tool. One of the more recent videos that I just checked out was the one with Dr. Winningham, who I think is a psychologist, if I'm not mistaken, and physical therapist Mike Studer, who talked about the benefits of dual tasking. And so I thought that was a really good webinar that I would recommend you check out following this one. Also, Neuro-rehabilitation.org, I mentioned a couple of times today. It's just a great resource that has tons of current and relevant research on there that I find very helpful in what I do, and kind of adding to my repertoire of information. These handouts here are examples of some of the really nice, clear, visually appealing handouts that you can print out from the website and provide to patients to explain a little bit about what's going on post-injury with post-traumatic vision syndrome, concussion in women, and that kind of thing. So it's just a great resource that I want to share with you all. And from that website, I kind of gleaned this little snippet, and it has some websites for other activity or other resources that I use. So covd.org, Sports Vision Pro, which is the International Sports Vision Association, and then the oepf.org, which is the Optometric Extension Program Foundation. So all of these are great resources that can provide you current and relevant information about emerging processes and information that you might want to know to kind of better your program and answer the questions that you might have that even I might not be able to answer for you. So I hope that I've kind of addressed the questions that you have. I really appreciate you having me on today, and I'm welcome to field some questions right now. I also provided my email here. I'm open to email if you want to reach out and send me some questions. I'm happy to engage in some dialogue with you that way as well. All right, so
yeah. Thank you, Liz. That was a wonderful presentation. Thank you so much. I think I'll have to give you gold for that one. Gold. But it was fantastic. Like, it really covered a lot of areas, and amazing work that you're doing with your patients. I do have one question here that someone had to leave early. So she would be keen to learn how the OT role is defined between the ophthalmologist, the vestibular physio, and OT retraining, as it seems a lot of crossover. And as an OT, I find I lack a lot of this knowledge for treatment.
Yeah, that's a great question, Beth, and that could be a whole nother presentation altogether. But I felt that way too, which is why over the years we've kind of learned to separate the two. Even though I think that there's a lot of overlay between visual rehab and vestibular rehab, I think it's just more beneficial, and this is just my personal opinion, to focus on one or the other. I think when you try to do too many things at once, things can get lost. So I just kind of focus on vision, and then my colleague, who's a physical therapist, focuses on the vestibular piece. In terms of the ophthalmology, which I would say neuro-optometry, so ophthalmologist is someone who does more surgery to a medical condition of the eye. But the neuro-optometrist is a good person that can delineate what visual deficits are there to thereby kind of create a roadmap for whatever provider is doing that treatment. So I think they're just they're very separated. So the neuro-optometrist is the evaluator and the diagnose, and then the therapist kind of either engage in the vestibular or visual. Obviously, if you don't have the ability to separate the two, I would just keep it simple and try to do, again, think about more of that peripheral gross motor activity and try to kind of avoid going too far into the minutiae.
Mm-hmm. Great. I know that we're running short of time, but if anyone else has any other questions, if you want to type it into the Q&A box and I can ask Liz, or feel free to either contact Liz or myself if you have any other questions, or Brian as well, who's on. Looks like we're all good, Liz, Brian. So thank you again. It was wonderful to have you participate in this webinar. We're very grateful, extremely grateful for both of you for your knowledge in this area. I'll make this recording available for anyone who wants it. And again, we do appreciate your time. I do have one question that's just come up. Oh, it's about a CPD certificate. So I'll answer that one later. All right then. Well, thank you again. Much appreciated.
No problem.
Okay.
Thank you.
Guys. Bye.
Thank you.
Bye-bye.